This is our final panel of prior to the president's panel, and I'm really pleased now to introduce it. It's entitled Building Trust, AI Governance and Ethics in Medicine and Health. And I really want to thank Dr. Kevin Johnson for being our moderator. He is the David L. Cohen University Professor of Pediatrics, Informatics, Engineering, and Communication at the University of Pennsylvania. So Kevin, take it away.
All right, thank you. Well, first of all, we've had two amazing panels, starting with, I think, a really great set of questions and thoughts and provocative comments around clinical ways that AI is going to be used, as well as a wonderful keynote and a second panel talking a lot more about innovation and discovery. There is this very, very large elephant in the room, which has to do with governance. And so this panel is going to focus on a question that many of you have already alluded to in questions. We anticipate that there will be many questions, and so we're going to make a couple of changes to sort of maximize the time for Q&A. So when I say, please get up, line up, pretend you're all Victor and fight for that mic and be number one. But you know, the issue of governance is pretty important, and it's especially important because sort of like politics, no puns intended, governance is local. And so much of what we have to talk about today relates to aspects of things like the models and how they are developed and how they're validated and whether they integrate into the specific workflow and solve the problem that they're intended to solve. And the question we have to ask as we move forward with that, as well as with performance, is how do we develop an infrastructure that can guarantee that, not just in an integrated delivery system, but also in the typhoon-ravaged parts of Alaska that might have primary care interested in ambient scribing. So we've been able to assemble, I think, truly a rock star team, and which is why I want to make sure you have time for questions. I could go into 15 minutes per person. I've known most of these people for a very long time. Please look at the book or use your Google. And by the way, if you think your phone is about to go off, raise your hand. There are many Gen Z type people here who will turn your phone off for you. Okay, so without further ado, we have Dr. Eric Horvitz, a fellow Stanford grad who I've known forever, who is the Chief Science Officer at Microsoft and does so much more, as you'll hear. Dr. John Halamka, who many of you may know, he is the Dwight and Dian Diercks President of Mayo Clinic Platform and the Michael D. Brennan President's Strategic Initiative Professor at Mayo Clinic. And the two of them will talk a lot more about both what AI is and how AI governance happens. Then we have Dr. Vardit Ravitsky, who is the President and CEO of the Hastings Center for Bioethics and is a real world-renowned ethicist and a major part of the AI Code of Conduct report that just was released by NAM, as well as many of us. And then finally, Dr. Robert Califf, the former US States Commissioner of the FDA, who's done that not once, but twice, and is now, and has been at Google and done many other things, and I'm sure that'll be reflected in his incredibly smart comments. So without further ado, let's begin with you, Eric.
Sure, so I'd like to start with a central idea we need to appreciate. AI is not a single technology. It's a diverse and evolving set of methods with different strengths, risks, and roles in healthcare. And the notions of risk and trust and governance vary by the technology and its application. So we're seeing AI applied to a wide range of tasks. And this, we've heard about much of them today, from streamlining administrative work to real-time clinical decision support. Some tools are built on traditional machine learning. These models are time-tested that have delivered value in critical care for over a decade now. They've been used to make predictions in hospitals about unexpected deterioration, for example. They've been used to reduce unplanned ICU transfers, to minimize failure to rescue situations. The other approaches, like on the frontier, like we're hearing a lot about and excitement about generative AI models. There's more uncertainty about these models for their performance, depending on the application, spanning administrative tasks, documentation, research. We just heard about biomedical research, decision support. And we're seeing great successes already with these methods. In just 2.5 years or so, ambient scribing is now blasted onto the scene. It's been quite successful and popular with clinicians, with nursing teams. We heard about tools that are helping with drafting responses in the patient inbox. Other exciting applications include medical imaging support. I mean, I was surprised just to learn about 1.5 years ago about new triage systems that are out that will, during emergency department cases, route radiologic films to radiology by cost of delayed review. So it's very, very nice to see this kind of the applications. So as we explore the applications, we need to think carefully about the role of clinicians in each one, ranging from full automation to oversight and monitoring, to direct engagement. And that role depends on the task. Administrative automation may require only periodic audits. Triage tasks might require semi-autonomous operation, but need clear paths for clinician override. Trust will be especially critical when it comes to clinical decision-making applications like diagnosis or therapy planning. So trust, in my mind, starts with transparency. It's critical. It's going to be critical to be clear with clinicians about what AI systems can and cannot do. We need to think as a community about, this came up earlier, about when and how patients should be informed. I believe that as AI becomes more embedded in clinical care, there'll be best practices will evolve about how and when to disclose AI use to patients. That's going to be a changing threshold, I think. Now, evaluation, as Kevin just mentioned, is foundational to trust. No matter what the use case, I think we need to understand that and be convinced that there's been a rigorous evaluation of the technology and to disclose that performance to end users. AI performance has to be validated before deployment. It has to be monitored during use. It has to be assessed using clinically meaningful metrics for the tasks at hand. For example, in diagnostic reasoning, we'd like to measure sensitivity and specificity, predictive value, negative and positive, and we like to sort of look at this issue around safety and make sure that we have representative caseloads to do these statistics on. On safety, especially for generative AI, we have to look beyond averages. Those ROC curves and so on. These are based on averages. Rare and serious failures, especially with these modern technologies, are actual safety issues. They have to be studied carefully, understood and disclosed to end users. And finally, clinicians and patients alike need education and training to understand the performance, to help them to appropriately calibrate AI recommendations, and to apply appropriate levels of trust. Now, a persistent challenge that is not well appreciated, I've discovered, is that AI models don't travel well. Several years ago, in a collaboration with MedStar, not far from here, we built models, my team working with leaders at MedStar, that were deployed at the Washington Hospital Center. We started with models that could predict the onset of hospital-associated infection within 48 hours, to predict 48-hour readmissions after discharge. These models perform great locally. But when we tried to deploy them, the models built at the Washington Hospital Center, just a few miles away at Union Memorial and Franklin Square. I don't know if people know this, these area hospitals here locally, other MedStar hospitals, they perform poorly. They need to be tuned with local data and revalidated. The takeaway is that every deployment needs local validation and then ongoing monitoring for drift over time. Now, in decision support applications, trust is also strengthened by helping end users, clinicians and patients, understand why a system has made a recommendation. There's been some encouraging progress on endowing AI systems with the ability to explain themselves. This is actually a multi-decade long pursuit, as people in AI have known over the years. It's interesting to see recent examples. In imaging, with generative models right now and discriminative models, attention maps or segmentation indications can highlight regions where the AI is focusing its attention. In structured data, for many years, we've been highlighting key factors that the machine learning pulls out, and we explain plus and minus why a recommendation is made or a diagnosis is made by these key kind of milestone features. But to be clear, explaining complex AI is still hard today. We don't have to wait 20 years for Peter's future scientists to say, I don't get it. Even today, it's hard to explain multidimensional, high-dimensional AI reasoning and making sure it has veracity and it's genuine as an explanation versus one that's made up to explain what the system just did, unbeknown to its former self. One promising opportunity I see is with building trust is to engineer provenance-aware designs where AI outputs are marked to clearly distinguish inferences made by the AI system, the factual data pulled from the EHR in quotes, and references to clinical guidelines and confirmed literature. So visual cues I can see like color, layout, citations can help users in the future, this hasn't been done very much to date, to distinguish the different sources and to interpret the veracity of content. Another powerful direction is for building trust lies in the design of the clinician-AI interaction. This is a rich, underexplored area. For example, we recently studied a workflow where clinicians and AI each made independent assessments for building differential diagnoses and planning next tests. The AI system looks at both inputs and is asked to synthesize and critique both. When we did this, it turns out that the structured collaboration, it draws on the complementary strengths of both sides and leads to higher quality decisions. I want to end with equity. You know, despite political wins, we must face the equity and diversity challenges in AI development and deployment. Now, Kevin and I recently wrote an article on this, an editorial. When we built models in the DC hospital, we found that race and zip code, they emerged as strong predictors of outcomes. Not because they should be predictors, but because they reflect structural inequities in access and outcomes over decades. It's tempting to exclude such variables and say our systems are blind to them, but that hides disparities rather than helps to address them. So we have to study and expose disparities. We have to design systems that recognize and mitigate them and build toward equitable care across diverse populations. I'll just end by saying equity in AI doesn't mean treating everyone the same. It means ensuring high quality care for all, regardless of background or circumstance. I'll stop there.
Well, you've teed it up really well. And I'm next, I presume.
Yes, you are.
Okay. So I was asked to think about quality, safety, transparency, some of these issues, and how has Mayo gone through quality management to achieve what we hope is trustworthy AI. So let me tee up a problem for you. So Mayo has 10 million patients. Of those 10 million patients, by the way, about 600,000 are pediatric patients. So if Mayo develops pediatric models, would you trust them? Well, how do you know what's inside? It says it's a Mayo algorithm. Doesn't that sound like it should be good enough? Wouldn't you want to know, to your point, the age distribution, the zip code distribution, the education, the income, the social determinants of health around any algorithm? And then you decide whether it's appropriate for you. So one aspect of what we must do to build trust is have a data card on every AI-related product, just simply telling you the ingredients inside, how we built it. And as Rob, I'm sure, will comment, just even knowing the data itself isn't enough. You really need to understand the provenance, who gathered it, how it was used, how its integrity was ensured, and that kind of thing. So Mayo says, sure, data cards for every product, but quality management to show you how we actually built the thing. And if you want to go back and test it, you can actually see along the way that audit trail. But again, not probably sufficient just to have a data card. You need a model card. How does it actually function when you deploy it in the real world? Because just because it's mathematically valid doesn't necessarily mean it's going to be clinically valid. I'm going to give you a completely absurd example. This is actually true. An engineer came to Mayo as an intern for the summer, and I said, here's some de-identified data, go build a model. And the person said, I have built the most amazing model. It's got an AUC of 0.99 for all patients. Well, that's great. Well, what is it? He said, well, Do you know if you give your inpatients high doses of morphine, their readmission rate goes down? Right? Right? And then he turns to me, what's a palliative care unit? Right? And so, great, mathematically good, clinically useless, right? And so you also teed it up very well that there's predictive models, there's generative models, there's agentic models. Each of these needs different kind of evaluation mechanisms. So on predictive, it is, yes, here's the data we used. Here is the model card showing how it performs in the real world. And then we do some additional clinical qualification. And so, for example, even if the model has a very good, performance in the real world, what happens when it goes bad? What happens when it makes a mistake? Again, a silly example, if I said, here's a model for ordering Band-Aids, and we order too many Band-Aids, it's okay, we'll use them. If, on the other hand, it's a closed-loop system controlling an IV pump, and on occasion it just gives you 10 times the medication dose, not probably an acceptable risk for many reasons. So there you go. For every predictive model, if you understand how it was built, how it performs, and the risk associated with its use, then you can decide if you want it or not. Let me make a quick comment on regulation, which I'm sure you guys may comment on, which is it to say that when we build soup cans and put ingredient labels on them and a nutrition label, that we only allow you healthy choices? The answer is we tell you what's inside, and if you want the can of soup with 3,000 calories and 5,000 milligrams of sodium, you can, but we told you what was in it, and that's up to you evaluating it for your particular use. So our sense is very similar on predictive AI. It isn't, obviously FDA, software is a medical device, there will be reasons for safety not to allow something into the market, but to say that there'll be a whole lot of models. And I'll give you again another example. We have a wonderful cardiology predictive model that predicts morbidity and mortality, and it works great if your body mass index is under 31, and really badly if your body mass index is above 35. Is it ethical to have such a model? Well, yes, if the patients using it have a body mass index under 31, right? So you make models available with characteristics, and then their use and application is decided upon. Generative is harder. And this is, here's an issue. So I'm an emergency physician. I went to medical school in the 1980s, which we had a wonderful dinner conversation last night that estimates only 80% of what I was taught was wrong. And so let's say we build generative AI systems, and Mayo has built 8 foundation models. It has a digital pathology foundation model, a genomics model, and a plain film chest X-ray model. And okay, those have AUCs somewhere 0.8 to 0.9. Do you say, oh, I don't know, I'm not sure I want to use a generative AI model if it has less than 100% accuracy? Well, the human, as we heard this morning from Chris Longhurst and others were quoting Zach, if I have an AUC of 0.6, using a generative model that's been tested at about 0.9 actually probably is a better thing to do. I think we have a hard time assessing quality and safety of the generative models because their very nature is that each time you use them, they may give you a slightly different result. So it's a bit hard to say. Just because I tested it at 6 p.m. and it was perfect, that at 6:01, it'll still be perfect. So again, with generative AI models, we ask, how are they being used? What are the applications for which we think their utility outweighs any risk, and that they're going to provide the human user with something of value? Now, agentic AI models, and we're starting to build some agents, will, for example, as we heard from Peter Lee, we have a model we're releasing that does self-discovery on large amounts of de-identified data. And do you know, Rob, it has discovered an amazing thing. People on statins have lower lipid levels. Amazing. It's amazing. And so one of the things about these agents that we're creating, yes, they will go out and do discovery, but then you have to subtract from their discovery known associations. So we're finding we're having to build knowledge graphs from the existent literature to create a sort of a base by which a new discovery will truly be declared new. Mayo has a goal of building 1,000 agentic AI models in the next 18 months. Many of them will be for administrative burden reduction, supply chain, revenue cycle, documentation, and that kind of thing. And we'll have to figure out ways to assess these things. So maybe I'll close by saying, my view, and many of us, I mean, we've all worked together, have tried to create coalitions of those from government, academia, industry, to decide what are the community standards. How do we build model cards and data cards? How do we publish transparently about risk? And so, not that there's a silver bullet, not that there's only one approach, but as you come together as a community and decide what's good enough, then these tools can at least be delivered to the customers with transparency. Thanks.
Vardit.
This is the ethics panel. So I want to start by reminding us that ethical and trustworthy AI has to be aligned with human values. And that's an accepted goal beyond health by any aspect of AI. So I want to use my very precious time to raise 3 points regarding what it means to have a human-centered approach to health AI. The first point has to do with transparency and consent. We heard earlier today that we don't currently have clear standards for consent and disclosure around the use of AI. And I want to ask you to do a little exercise with me. You're sitting in this room, you're naturally wearing your professional hat. You're thinking of yourself as a clinician, as a scientist. I want you to take off that hat and put on a patient hat. I want you to go into your patient identity for a minute and ask yourself, if there's ambient recording in order to take a note from my clinical encounter, do I want to know that this is happening? If I'm getting a message and I'm thinking it's from a human clinician, but it actually came from a chatbot, do I expect to know? If my mammogram was read by an algorithm or my brain scan, would I want to know? If my insurance claim was denied because of an analysis based on an algorithm, would I want to know? And really sit with that question, and if your answer was different across these use cases, ask yourself why. What was it about those different examples that caused me a different level of comfort regarding knowing and not knowing? In the literature initially, we saw an ethical position that said patients should be informed about everything and they should consent to every use of AI. It's new, it's risky, mainly for 2 reasons. Ethically, because they're autonomous and they have a right to know, and pragmatically, because if we don't do it this way, we will lose trust in individual clinicians and in the healthcare system, so we should always disclose fully and be completely transparent. But the truth is that will not work. First of all, surveys begin to show that patients and clinicians, as the stakes are higher, their level of trust in the AI tool is reduced and their expectation for disclosure is increased. So we obviously have to tailor our approach, our human-centered approach, to use cases. Second of all, this is already the case. You know, if I'm pregnant and I come in for an ultrasound, my consent is implied by the fact that I showed up. But if it's an amnio and somebody's going to stick a needle in my uterus, the level of disclosure and consent is obviously different. So we already tie consent to levels of risks and to standards of care. I hear everywhere this analogy that when a patient steps into the hospital, they're not informed, they don't consent to the use of electricity in their care, right? It's just assumed that you're there, it's going to be a part of what will allow us to care for you. What happens when those certain AI tools are so well integrated into your care that they become like electricity, and we completely lose the concept of transparency, disclosure, and consent? So this takes me to the second point, which is, what do we expect and why? Right now, we talk about the human in the loop as an aspect of accountability and an aspect of trust. We heard that even for the scribe tools, the doctor must read and edit the summary if it's a message, A human will see it before it goes back to the patient. But I'd like to challenge that with two questions. What happens, as we heard, when it performs better without the human in the loop? And also, what happens when the integration is so complete that the human in the loop just doesn't make sense anymore, even if it doesn't impede the performance? So I want to call your attention to this phenomenon, where's Peter, that he calls the flip. Think about liability. Right now, you could be sued for relying on AI, and that would result, imagine, in harm to your patient, and you could be sued for over-relying on it and not disclosing properly. A year from now, your main concern might be to be sued because you did not use an available AI tool that would have provided better care. So when do we flip the standard of care from something is new, risky, requires special explanation, special consent, and has to keep the human in the loop at all times, to it's obviously a part of the workflow, everybody expects it to be used. If you didn't use it, you might get into trouble. Do we have the governance, the frameworks, the metrics for knowing when that flip occurred? And that is really a question for each practicing clinician, considering we don't have standards, each healthcare system, even hospital, implements the tools in a different way, at a different rate. How do you, as individual providers, know what you're liable for, what you're accountable for, and how to optimally provide care to your patients? And the last point about human-centered approach is this. I sit in many rooms and hear clinicians say that they're afraid of being replaced by AI. And I hear young people who consider a career in medicine wondering if there will be jobs for them when they finish their training. And these are very serious concerns. But we also hear the sort of classic response, which is AI will not replace doctors. Doctors who use AI will replace doctors who don't use AI. We hear that everywhere. But I push further and ask, what aspects of care should remain fully in the hands of humans? Where should we kind of stop this integration and the obviousness of having AI tools as a part of our care? What if chatbots and later care robots sound and seem to provide high levels of empathy, compassion, patience, a sense of caring? And this takes us to a very philosophical question. When we want, as patients, to feel empathy, to feel cared for, does it matter if it's not real, in the sense that it is not felt by the entity that provides it to us? Is it enough that we feel it, even when it's not real? How will this matter as the integration of the tools into our care becomes like electricity? So I want to end with this. There's this new phenomenon, I don't know if you're following the literature on this, called AI psychosis. So I asked AI to define what AI psychosis is, because it's such an emerging concept. And it is basically when people develop deep, meaningful relationships with their generative AI counterparts to the point that it blurs the lines between a digital conversation and reality, and people become convinced that they're conversing or having a relationship with a conscious being, a sentient being. And they develop these expectations for this relationship to the point that we've seen suicides and self-harm when the counterpart gave bad advice to the human. So if the tools are so powerful that they can lead to this psychosis, that we can be convinced that we're really heard, understood, that there's empathy for us, what does that mean for how we should, what lines we should not cross when we integrate the tools? What are humans good for is the question that we're asking at the Hastings Center, and what should remain protected from AI intervention? And I want to congratulate really the National Academy of Medicine, Lara and Sunita, for this amazing work that we were all part of, the Code of Conduct, because the first commitment of this code is advance humanity. And that framed the whole conversation. There are copies outside. Pick up one. So a human-centered approach for AI, what does it mean for consent and disclosure? What does it mean for accountability and standard of care? And especially, what does it mean for the care relationship? I'll leave you with those questions.
Rob.
Okay, thanks, Kevin. And let me just preface this by saying, as you know, I'm just a country doctor from South Carolina. You guys are all, really smart, and I've written a whole page of notes, so this may come out befuddled, but I'll do my best to try to make a couple of points. The first is a question. Why should people trust? I see there are 3 words in the title here: trust, governance, and ethics. How do they relate to each other? We're in this room currently the leaders of a health system in a country with the worst outcomes of any high-income country and far and away at the highest cost. If you were going to people who are running that kind of an organization, why would you trust them? Now, I'm not only a country doctor, but I'm also battered by having been in the last administration, and I have spent a lot of time trying to understand what's at the core of this lack of trust. And there are many theories, but I think you'd be hard-pressed to not believe that one of the main underlying features is that we're talking about all kinds of fancy stuff here. When people can't get an appointment to see a doctor under almost any circumstance, even faculty of our best medical schools can't. So what is it that we're doing with this AI that would engender trust? So 3 things I want to emphasize related to that. The first, now that I'm out as a free living human being again, an instructor in medicine, so I can ask, naive questions of our leaders, I'm just an instructor, is as I look at the deployment of AI, yes, there are a lot of cool things that predict clinical outcomes and some nice studies that show some improvement in a system that overall is not trending in the right direction, at least compared with our peer countries, which have much less sophisticated information. What are the criteria that our purchasers are using to make the decision about whether to deploy an AI? Overwhelmingly, it's the net present value. Now, the net present value does not, unless you're really sophisticated, include anything about the patient outcome. And so what I'm hearing from my clinical colleagues as I'm back in the world again, in the systems that they're working in, who we're arguing should be trusted, the value of finance is here, the value of well-being of patients is here, despite the fact that we're saying we're all patient-centered institutions. And I don't know about you, but at least where I came from, if someone says, I'm looking after you, but they're really not, that is much worse than saying, I really don't care about you, I'm not looking after you. You might as well accept that. And that is the experience that people are currently having. And I worry a lot that as long as the net present value is the central focus of what we're doing, that we're going to make things a lot worse with AI. Now, I have a little bit more to say about that in a minute. The second, all of you have in a way made this point, some very, very overtly, but I think it's really, really essential. You cannot trust an AI unless you're constantly validating it. An AI deployed for health is essentially a patient in your intensive care unit and needs a monitor. So it's a term, local recurrent validation, which I think it's so hard to sort of accept that it's true because a person like me grew up thinking you did a clinical trial, you prove the principle, then you deploy it. But when it comes to AI, if you leave it alone and let it sit there, it could either get better or it could get worse, and you don't know unless you're testing it. And I love the point that you made, the point if you move it 2 blocks away, it may no longer work. Now, we're talking about governance and trust. Is there a health system in the United States today that can actually logically do local recurrent validation? I would argue no, although Mayo's coming pretty close, and I think the institution I'm part of now is making a good faith effort. But to do that, anyone who's done clinical trials knows you need the total longitudinal patient record. And we have a system in the US which is built to make it really hard to put together the total longitudinal patient record. Because people go to different health systems, they die. What's the thing we know the least about now? Dead people, because they're no longer submitting bills, and so our electronic health records don't collect whether you're dead or alive. It's an astounding fact, but as you know, anyone who does clinical research knows the most important information in clinical research is in people who go on to die, because that is the most important outcome that people are most concerned about. So you have a system built not to be able to do the one essential thing that we need to make this work. I would argue those who are in charge, who are governing, should make it their business to fix this problem. It's not as if we didn't know 30 years ago that we needed a national patient identifier and longitudinal records that were coherent so that people went across town. Right now, you can get the transaction through the health exchanges, but you can't get the kind of data that you need to make sense of outcomes studies. The third point I want to make is, yes, I am a regulator, former regulator recovering. I do think regulation is needed. But the kind of regulation that you think about with FDA is really only needed for very high-risk deployment of AI in traditional devices. But there is a part of FDA, remember the F in FDA does stand for food, which I think is the right model, not nutrition. That is a disaster in this country. By the way, I had lunch with the fellows at Mayo Clinic 2 weeks ago. If you wanted to trust Mayo Clinic, why don't you cut the portion sizes from, I couldn't believe it. It's just amazing. But the food system works because it was impossible to have an inspector on the farm every day to see what's happening. And so what you have is 10 foundational principles that everyone has agreed to. That is really the code that you have to have, whether you're a farm, a distribution center, a warehouse, a restaurant, or a grocery store. And we could do a hell of a lot better with regard to nutrition, but when it comes to food safety, we're pretty good. I ate my cookies today. I wasn't worried I was going to get sick, and you shouldn't have been either. And it astounds me that we now have opposition, apparently, to groups of institutions banding together to develop principles. But we better do that, because if we don't, I think we're going to be in trouble. And one of the principles ought to be that patient outcomes should be a mandatory assessment as part of deciding whether to deploy an AI. Then the last point I want to make gets back to the fundamental issue of trust. I think the reason that we have the worst outcomes is not because we don't have the best neurosurgery in the world. It's because the things that are affecting people's health every day are the most important, and we're paying no attention to that, and I didn't hear it at this meeting. With an entity which has done an amazing job of defining social determinants and ideas about what to do about it, why don't we deploy AI in a trustworthy way to deal with the simple things that really make the difference in health? What you eat, whether you're using tobacco, whether you exercise. And I know there are people working on that, but it gets 1/1000th of the information that fancy neurosurgery gets. Now, if I have a brain tumor, I want fancy neurosurgery. But if we don't pay attention to this other part, I don't think that there's anything we're going to be able to do that's going to regain the trust of the population.
Well, once again, they didn't disappoint. I would encourage you, if you have questions, to make your way to the mic. There's mics on either side, and there's a few floating, but please come down. Just to get things started, I do have one question for you all. We've talked about trust, but we've also talked about, earlier today, these models are ready. These models are doing things that actually can significantly transform care. How do we balance this? How do we handle the fact that a model may work perfectly well in a very narrow environment, but we know it can't scale, but should we install it? How do we handle the issues of, as you put, Rob, very eloquently, aside from the issue about Mayo portion sizes, that the healthcare system may know what we should be doing to help with care, but we don't value it the way we value what we can get paid for, so-called contribution margin. So Vardit or others, can you just help us balance or think about how we should balance these?
So First of all, I think if we let economic factors lead the implementation, we're going to lose a transformative opportunity to use these tools to close health gaps and to promote equity, and we'll end up with exacerbated inequity. And therefore, having the ethicists around the table to remind us, you talked about diversity and inclusion and the data and the deployment, you talked about what bothers real patients in daily care. We have to have those voices, the patient advocates, the ethicists, the regulators around the table with the developers and the CEOs. And that's what happened again with this code of conduct, where we sat together and thought about how this will impact equity. But I want to say something more general. We chatted with Christine Grady this morning, who led bioethics at the NIH for years. And we agreed that one of the problems with bringing values and ethics to this conversation, and I can attest every time I'm invited to a room, the expectation is, since I'm wearing the ethicist tag, that I will be the naysayer, the one hitting the brake, the one with the precaution and the slow down, and let's not do it. I need to focus upon the risk and the concerns and the fear and the why not. And that's a problem, because then there's a pushback. I see bioethics not just as a facilitator, but even potentially as an accelerator. Because what happens when we integrate all these tools unwisely? I mean, we have safe and effective interventions, they're called vaccines, and we're worried about measles. So without trust and without paying attention to the societal, cultural, political context, the economic context, we will not optimally use these tools, and we will see a social backlash. I'm always afraid of the first day we're going to wake up to a front-page New York Times story about the AI-caused death of a patient and what that would do to the social perceptions and to this potential backlash. And so I see ethics as walking hand in hand with the innovation, with the incentives, with the developers. We have to do it right, or else we will not be able to deliver the promise.
I could say that there's opportunity for the narrow experiments and randomized controlled trials with these AI systems to learn a bunch of things about the world that can be generalizable. And it's not just about how AI is to be used in daily life, in clinics, and for the Southern doctor, for example. It's also maybe new policies. So one example comes to mind right now that I'm grappling with is Peter Lee mentioned our sequential diagnosis project, which we're now applying to ED cases, emergency department cases. So it turns out at Beth Israel, Adrian Haimovich, who is a researcher and a clinician at the ED, says 10 to 15% of ED patients that they discharge from the ED come back and are admitted within 72 hours, a bunch of whom come right into the ICU. Could we capture those patients earlier with smarter AI technologies? Well, our methods show the average cost in running the system, which is different than the human assigned set of tests. And it's going to probably come down to how much we're willing to pay to reduce that number, and how much better do patients do with paying more. Who decides on that trade? That's an interesting ethical question if it comes down to cost and profitability of even hospitals. So there are some interesting decisions to be made that can be illuminated by these AI technologies, looking at large data sets and operating, for example, in a diagnostic manner in ways very differently and potentially more deeply and more thoroughly in terms of the cost-benefit trade-offs than would be present in the minds of physicians as they handle case by case.
John, Rob, if you could make it short, that would be great.
Very short. Okay. So I think, as you both highlighted, we have to ask, what does the patient want? And if the patient comes first, and we take it through the eyes of, can the patient get the right care at the right time in the right place, right cost, right quality, that's going to help guide us. But here's why it's complex. So Eric Schmidt used to run Alphabet. He's on the board of Mayo. He said, when we started this Waymo company, we actually did a cultural analysis, and we found that the public wanted the Waymo to be 10,000 times better than any human driver. And so we actually had to engineer it to be 10,000 times safer before we could deploy it. So this is our challenge. The patient should get the benefit, but there are cultural considerations at the same time.
I would just say that I've evolved in my thinking. I am not at all worried about trust in AI. I get in my car and, it tells me where to drive. I don't ask, why and how it all happened.
A-star algorithm.
I think the problem we have, as I said before, is more fundamental. So let's imagine what a key principle would be. If a principle was that we actually intended to reduce inequities in health outcomes in the region of our center, we would do it. But we don't have that intention. It is not an explicit goal, and I would argue the biggest use of AI in healthcare today is to segregate people in whom you can make money from people in whom you cannot make money. This is sort of astounding to me, but if I read it correctly, 80% of the expendable dollars in the US now are owned by 20% of the population. Who cares about the other 80% if your goal is to make money? I think if we had principles that we actually had to adhere to, like the food system does, we'd have health outcomes that look sort of like food safety. It wouldn't be perfect, but it would be pretty darn good.
I really would like to nominate you for assistant professor. I think you're ready.
Well, some of you have heard this story, but I have to submit a development plan before I can. 74, I thought a funeral strategy would be the thing.
Okay, question over here to begin with.
Hi, my name is Claire O'Hanlon. I'm with the RAND Corporation in Santa Monica, California. A couple of people have talked about how these models don't travel well. And given the potential costs of local validation and local recurrent validation and all these things, how could this possibly be deployed equitably across our healthcare system or not massively raise healthcare costs?
Anyone want to take that?
Well, I should say that there is a kind of pursuit of fit for purpose when it comes to the ability to have models travel. So, for example, these scribe-style applications are quite portable. We were referring to some of the deep diagnostic reasoning, which requires consideration of the demographics, the prevalence rates, the covariance that comes in the population for the distribution of patients. That's a little bit more difficult. I do think we can address that over time with more automation, monitoring, and tools to help with fine-tuning and for keeping models up to date at local centers. So I don't think it's the end of the game on that.
If I could, I mean, John might just have 2 sentences on this because he's doing it at Mayo Clinic. I don't think there's an infrastructure cost to be able to validate and monitor your models. Once you've got the basic infrastructure,
right.
I don't think it's very expensive.
All right, so some of the models do travel well, like radiology interpretation, EKG interpretation, that sort of thing. So those could be deployed pretty much anywhere. But as you suggest, there are stacks of tools that can run in local environments at very low cost that can report on the performance in a local environment.
We don't have those yet, don't get me wrong, but it could, it's not rocket science.
And the dream is to scale up the best practices and the best engineering and the best tools and make them available.
Great, thank you. Next.
Hi, thank you so much. Diana Montoya Williams from the Children's Hospital, Philadelphia and Penn. Our country is 20% of people who speak a language other than English. And as an immigrant health researcher, I definitely see the benefit of this type of technology to close language equity gaps, both for healthcare and research recruitment. So how can we be proactive with respect to regulation and ethics as we think about the very real future where AI is potentially a real-time interpreter or an asynchronous translator of healthcare interactions?
These models are stunning in their ability to translate. I mean, it floored me as an AI researcher just 2 or 3 years ago to see that power. And I applied them to medical cases and demonstrated them for medicine. We even did work with Trevor Mundell at Gates on different languages in the Southern Hemisphere that would help
That could be another principle. And I know that Karen DeSalvo is in the audience, and I'm an amateur at this, but one of the great things I learned in my 6 years at Google is seeing how they had this army of people for translation, and now it really, you can speak any language into Dr. Google or whatever, and it really is handled. But we just have to decide to do it. The cost of the translation now is practically zero.
Yeah, there's no reason why that shouldn't be diffused widely in healthcare.
Though probably still worth testing.
Sure.
Thank you. Over here.
My name is Kira McHugh. I'm from Howard University. So besides what-if scenarios, what kinds of logic validations are you using to train your AI? And if so, are you considering deductive reasoning, probabilistic reasoning, cause and effect, or syllogistic reasoning?
So there's lots going on to better understand these systems. I should say that to most AI experts, there's surprise and mystery in how well these models work and where and when they fail. There's a whole area called mechanistic interpretability. There's work going on. I'm involved with a Bayesian reasoning probabilistic interpretation and training of these models to be like probabilistic reasoners. I think that's the frontier right now. We're making progress in that realm. One related answer is, just not to get too long-winded about this, is I didn't mention how critically important it would be to have models be able to understand how to emit and assign their own inferences well-calibrated likelihoods or competences. That would be useful in across the span of usages, including when a system makes a diagnostic claim or builds a differential, really have a good probabilistic backup for what it's doing or saying. We've seen that in some cases, and there's some papers in literature about how to make models better calibrated so they have a probability you can trust, but that's still the frontier of research. I'd love to see where we are on that like 10 years from now. I think we'll solve that problem.
So for example, we cannot explain how our cardiology models do what they do, but they do it really, really well. So we did RCTs. So that is, we actually took 125,000 patients and we looked at ground truth and we tested the model, and what we found is its AUC was 0.93. We can't explain it, but it works really, really well.
But we also can't really explain how aspirin works or how GLP-1s do what they do. So that doesn't bother me at all. It's the empirical proof.
Right.
And Eric, you mentioned the word calibration, which I think is one of the big missing pieces for most evaluations. You can have a model that discriminates really well, like the RC would show, but if it's not calibrated well when it comes to practical application, you can
Right.
have a real problem.
It's hard to use a model that can discriminate well that cannot give you a probability in a decision-making task, is the point.
And from the patient's perspective, a couple of years ago, if you looked across the bioethics literature, there was this expectation that to really have proper consent, you'd need the model to be explainable. And that has been completely abandoned, I think, based on your notion, I get in my car, it takes me where I need to go. So it's really about outcomes. And also this notion that some people call AI exceptionalism, the 10,000 times safer than. What we drive, the rate of human error would be the proper comparator and not 100% safety, right? So if you think about patients' access to your brain, as a clinician, do they really understand the black box that they're currently facing compared to these black boxes, which is a...
But one thing that we need to study, I mentioned this briefly in my comments, is when there is a failure, the 0.07 in the 0.93, right? What's going on in that dark matter, and how do human failures, in terms of their cost, the morbidity, mortality, relate to the model failures? We have to study that very carefully, because that's so. What I give a couple of grand rounds right when GPT-4 was new, and I showed how great these systems were, and I showed the Department of Medicine audience, look at these, how it's solving all these problems. I always threw in a disaster that was hard to pick out, that would have killed the patient, because people need to see that these things can happen, and we need to sort of characterize the rare failures that are safety challenges.
They look the same.
Even when we have good AUROCs on average.
Yes, question.
Thank you very much for your talk. I'm Melissa Simon. I'm from Northwestern University. Part of trust is understanding the power dynamic. And I really appreciate the comments. And I'll be a part of your mentor team for a K Award if you'd like to apply, by the way. I think you should go for tenure. Part of the power dynamic in this is very similar to like the digital divide that happened a while ago and health literacy and all these them versus us. And it carries through to the theme that we talked about yesterday and the distancing between the public and their trust in what we do at the academies. And what we're doing in my lab, and I'd love to see more people do it, is having community members, patients and community of all identities, actually inform the AI algorithms. So when it comes to having the fancy stuff to support me as an obstetrician in clinic, it would be really great to have AI support the patient and their communities from which they come in interacting with me and feeling more empowered and engaged to interact. But that comes with building trust from the community side and the patient side, but also really important is not just getting data that we're inputting from the medical side and the practice of healthcare into the AI algorithm, but from the patient's perspective, what do they really hear when they're listening to a risk score? Or when they're talking about, when they're listening to the different treatments that your AI algorithm said that they would be the best for.
Let me stop you. That was great. And the question that I'm hearing is, to what extent do we know what patients need to hear to trust these models?
I was privileged to lead off a NHLBI digital twin meeting a couple of weeks ago, so I read up as much as I could. And the new definition of digital twin is it has to include bidirectional information between the twin and the original object. And so I think a quality of AI that could, AI also is a bunch of technologies, as I think you rightly said. The quality of it is it could I think it would be the greatest way around to actually figure out what patients wanted to hear, because in asynchronous learning and interaction, you could really have a whole different interaction with your doctor or nurse practitioner. What I'm worried about is, let's just take an example. One of the 30 million combustible tobacco users in the United States. The AI would say, you need to get your doctor and the place your doctor works to really put together some great stuff for tobacco cessation. Well, show me the health system in the US that's doing that. So I think the AI and the interaction would be priming a set of discussions that could lead to a lot of anxiety, both in the patient and the clinician. This is just a thought.
Oh, I thought there was more coming. That was
stop there.
Okay.
The rest, you don't want to hear the rest of it.
Anyone else?
Well, I mean, your question gets at the role of patients, the role of physicians, the role of administrators from the very beginning of developing and fielding AI systems. For consumer-oriented systems, that's a whole set of questions comes to mind. How do they work? How do they ground with patients? How do they exude competences that are somewhat well calibrated? How do they do triage and referral? I think there are projects in those spaces, but many are very much researched these days.
I do want to point out that we have a scoping review that's about to come out, and we found 61 papers that are related to AI in primary care, only 6 of which have gotten past the development stage. So there's an enormous amount of work to be done, and I would argue that this is the big challenge, that getting it over that next line, not everything that can be researched ever gets to production, et cetera, is going to be the big challenge that we have to face. And it's, in part, understanding these questions, and I think coming to grips with the idea that these won't be all created equal, but they might be useful for some group, and we should learn which group they're useful for, which is what Eric said earlier. Question here?
Awesome, thank you so much. Hi, my name is Sanji Franks, and I'm representing Howard University.
So I have a two-part question, and it begins as medicine becomes increasingly intelligent through artificial intelligence, how can we define the clinical automation threshold and establish global standards that ensure evidence-based algorithms that enhance rather than erode physicians' judgment and empathy, while validating studies, quantifying the risk tolerance, ethical ROI, and equity impact that safeguards public's trust in both the science and humanity of care?
That's going to be the only question because we have so many. Just so you know. So thank you. Anyone?
Well, I'm going to react to that because, I think it's a great question, and it did encompass almost everything that we're talking about. But why are we asking AI to do things that our human systems don't do at all? Cardiology is the most evidence-based specialty documented through empirical research, but 10% of our major recommendations are based on high-quality evidence. The other 90% aren't. So I would hope we could at least make AI, as imperfect as the human system, and not worse. But I think the things that we talked about have covered that if we actually did them, but we're not necessarily doing them right now.
I think that's right. Thank you. Yes.
Consuelo Wilkins, Vanderbilt. Thank you for the thoughtfulness you all put into considering disparities and equity, and also for perhaps distinguishing a little bit between building trust and being trustworthy, which I think is critical to trust. We talked a little bit about the different populations that are experiencing disparities by race, ethnicity, zip code, et cetera. Many of these groups have different experiences with trust. In the health system, in research, they've been historically abused by us, but they're also being currently abused by us. And so I think if we're expecting to consider what Vardit talked about as person-centered, we can't take those individuals and consider them just as individuals. We have to think about the group's experiences. And so I'm wondering how we might use AI, or if you're already using AI, to help demonstrate the trustworthiness of the health system. So, for example, we know that, can I give an example though? So for example, we know that in some places, clinicians are spending less time in the health records of people of color. So can we use AI to give that feedback to clinicians to say, you're spending less time in these people's records, and or something along those lines, or you're making more mistakes, you're not giving the best evidence, the 10% of evidence in cardiology to this group. Can we use AI to actually improve the health system and how we're delivering care to some groups in some way?
I want John to answer this because of how much time the Mayo has spent actually implementing. So to what extent have you confronted this issue of unequal care?
Sure. So one of the challenges is that as you even develop the models, right, every model is going to have bias in it because you may not have the completeness of the data you'd like. So what we do is we look at the address of every single person at Mayo, and we've mapped for every address in the United States access to grocery stores, access to primary care, employment numbers, crime numbers, educational opportunities, and we actually use those 40 variables as part of every model we create. So it's not exactly measuring the process as you describe it, but it's trying to say, before we even start, let's understand the challenges of every person that we care for based on where they live and some of the systemic aspects of their community, which would make their experience of healthcare different. To your point, though, on process, I mean, certainly as we start to develop these agents, this next agentic AI activity, we'll be starting to look at business process and flow and trying to make those adjustments in a patient-centric fashion. So that is a next step.
Kevin, if I can just make a comment.
Please.
I'd like to refer you to, and people interested in this topic, to the work of Dan Diercks at Stanford, by analogy, looking at large corpora of body cam footage with audio and how police officers of different races talk to drivers of different races, leading to training programs, AI analysis of the language, leading to training programs to work out the biases and to get people a little bit more balanced in how they approach human beings.
Lots of work to do in this space, no question. Vardit, I can tell you have an answer you have to say.
You made me think about the AI tools that are attached to Zoom, for example, probably something you're all using, that at the end of the meeting tells you how much time you spoke in relation to other people, the tone, were you dominant in the conversation. Of course, these tools should be deployed as much as possible to identify these things. But I just wanted to throw in a completely different aspect to the mix. Philip is here. We're part of the Bridge to AI initiative of the NIH, where we're using AI within biomedical research. And one of the projects, for example, looks at the human voice as a biomarker of disease. So here we are using AI to promote a new diagnostic tool that would be cheap, non-invasive, and accessible to people everywhere, regardless of their geography, because you would be recording yourself at home. Okay, digital divide notwithstanding, if you have a smartphone, you'd be recording yourself, uploading to the cloud, and allowing your clinician to provide better care. And this is seen as a public health equalizing use of AI. So beyond measuring our biases in the clinic or fighting algorithmic bias in our data, we can actually prioritize uses of AI to develop new tools that would actively promote equity and access to communities that historically had less access.
So Vardit, may I point out that preferences and sensitivities vary by organization. And to use an example here, Teams was delayed by about a month in shipping when we decided, the Sensitive Uses Committee at Microsoft, that those kinds of questions were too sensitive to ask Teams. That you're saying Zoom is doing now. So it's interesting how it was tuned to just quietly refrain from answering questions about dominance and who was talking the most.
I have to tell you that the first time I got the report about my role in the meeting, I had to, take some time to consider my own identity.
You switched to Teams, right? We have time for 2 more questions, and I'm sorry for everybody else. I tried my best, but if you ask your questions and they're short, we'll be able to move pretty quickly. Which side am I on? Over here.
Hi, my name's Dakota. I'm a current medical student. There was a great comment made about how we have a new generation of physicians, those who know how to use AI and those who don't. What I'm noticing is that there's a great eagerness for students in my cohort to use AI, but we don't have a lot of techno-pessimism or a lot of skepticism for the tools that we're using. We just accept what they say is gospel. As a student with a background in bioethics, I get that I need to question everything, but for students who don't, my question is, what is the burden that medical schools have to make sure that we're able to mindfully engage with AI and not just see it as another tool?
And so, Kevin, I have met with medical school deans across the country and said, stop teaching the Krebs cycle. And of course, they look at me and they say, but it's the foundation of all modern pharmacology. Teach data science. Teach AI ethics.
Yeah, and John, I was amazed. I'm working with students around the country now because I've lost hope that the institutions are going to be able to react to what's happening. They're still memorizing note cards to pass the boards.
Exactly.
When all the information is sitting right there on the cell phone. So the institutions have got a long way to go.
I think you're hearing that there's a real conundrum right now between the ways in which we currently sort of pedagogically know how to teach and test versus what we expect the future to have. So let's hope for no AI winter, and that we will then get out of your education all of the things that we know, like phlebotomy, you'll never need. So there's that. Yes, sir.
Sam Silverstein, Columbia University. This is a nuts and bolts question. Given the fact that AI is trained on current data, don't we need to revisit the infrequency with which we're doing postmortem examinations now?
Oh.
That was your comment, I think.
Said postmortem examinations.
Yes.
So you're referring to autopsies?
Autopsies, yes.
Not examinations of the AI. We would learn a lot if we did autopsies. And you talk about the ability to make use of what used to be just a pathologic specimen. We would learn a lot. That's awesome.
And there's quite a bit of dark matter in the data. Like, for example, at University of Washington, we're collaborating on a project on incidentalomas. How do you track them to the system? What happened with them? How can we learn from outcomes that are hidden about what we do with an incidental finding in an imaging study?
I want to move on to this question, but I do want to take moderator's prerogative and say, by the way, we have no outcomes data in the EHR for virtually any diagnosis. Right. So what we really need to be thinking about is where in the EHR should outcomes live. For example, we were able to successfully treat this patient's hypertension, because right now we would train on all of those data as if all were equal, and we know that they're also not. So it's a great point. Yes, final question.
My name is John Birch. I'm with the Health Record Banking Alliance. A brief comment on what Rob mentioned, and I hear this so often, the fact that there is no way of doing a 100% longitudinal health record. There really is. There's no incentive for it. There's huge need for it. And I hear it again and again and again and again. There's no incentive. We are working on trying to create incentives for it. I'll just leave it at that.
All right. Well, thank you very much. First of all, I just want to thank the panel. You all were terrific.
Well, first, let me thank Dr. Johnson and this amazing panel. Let's give them another round of applause. That was really beautiful.